A very good evening to everyone, and welcome to our seventh session of the Nomics series. The series is designed to empower clinicians and healthcare providers, and for anyone interested in learning more about how genomics is being utilized across various clinical and healthcare settings. I'm Dara, your host for this webinar, working at Karkinos Healthcare as a bioinformatician. Today we have with us Dr. Srinidhi Nathany, a distinguished molecular hematologist and oncologist currently practicing at Fortis Memorial Research Institute in Gurugram. Thank you for joining this session. And let's begin this session. And I will take this opportunity to give a brief introduction. So before we all listen to her insightful presentation, I would like to take this opportunity to enlist her illustrious academic background and a plethora of accolades. Dr. Nathany earned her MD in pathology from Kasturba Medical College in Manipal, graduating as a gold medalist. She further honed her expertise with a fellowship in molecular hemato-oncology at Tata Memorial Hospital. Her credentials are further bolstered by her FRC Path UK and a diplomateship in molecular pathology achieved in 2021. Dr. Nathany also holds a master's in molecular oncology from the European School of Oncology in Spain. Her scholarly contributions to the field are substantial, with 52 indexed publications and 20 abstracts. Her work has been recognized with several prestigious awards, including the Rashtrapati Puraskar in 2005, conferred by the Honorable late Dr. APJ Abdul Kalam. She has been honored with the Scholar Collar by MedEngage and the Maharashtrian government. Please join me in welcoming Dr. Srinidhi. The stage is now yours, Doctor.
Thank you for this introduction, which I clearly don't deserve when, such accoladed people are already there in the panel, like Dr. Skaria, and I can see Dr. Jyoti Vajpayee, and I also know Mr. Vittala, and I don't know other people. Okay. But thank you so much. Thank you so much for the invitation. And I hope I can do justice to what I've been invited for. I think it's just on the basis that we did a little study on germline variants in lung cancer when I was at my previous institute with the pioneer in lung cancer in India, I think Dr. Ullas Batra. So today my job is to talk about germline testing in lung cancer. And whether to do or not to do is a very big question, especially in the Indian setting where money is always a problem. And doing a germline testing in lung cancer means searching for a needle in the haystack, because not really many people know that what is in store and what are you going to do with it when it comes. So let's just dive into the topic. And so why are we talking about this today? So I think now in the era of molecular medicine, the paradigm has shifted from matching a Janam Patri to Genome Patri. People were already doing it with thalassemia. And I think, with more and more hereditary cancer predisposition syndromes, and not only cancer, but even benign disorders, autosomal recessive disorders especially, make you actually think twice that, what are we doing, and are we getting into the right alliance? So at least people like me who are aware, and some people like, there are people who are aware of what happens in the genes, or also, talking about this today. So it's very important we talk about this today. So is lung cancer is a disease of the smokers only? The answer is a big no. And why? Because 15% smokers get some form of lung cancer, which can be small cell or non-small cell, but a very equal proportion, 15 to 25% of never smokers also get lung cancer, in whom no other extrinsic factor can be identified, like ionizing radiation or any other, occupational hazards like asbestosis or anything. In fact, they have inherited risks analogous to hereditary breast ovarian cancer syndrome. So what do I mean by inherited risk? That, there is some gene mutation which is causing lung cancer. So my talk today would be centered around these questions, which are: what is the hereditary mutation landscape of lung cancer? Are there any specific alteration with respect to the type of lung cancer, that is, non-small cell, small cell, or squamous cell carcinoma? Are there any protective alterations? So interestingly and intriguingly, there are one or two protective alterations that if you have that mutation, probably you won't get a squamous cell lung cancer. Although I think it is very elusive and we really need more results on that. Then whom to test, which test to order, and some very futuristic ideas. So just a few basics of germline testing, that whom do you call positive, whom do you call carrier, whom do you call uncertain, and whom do you call negative. So positive is a person who has one or more variants, which is classified as a pathogenic germline variant. So when I say pathogenic germline variant, it is basically on the basis of guidelines laid down by the American College of Medical Genetics and Genomics. And it is very important we really understand those guidelines, because there is a new version, there's a secondary finding list, and there is an extensive gene list which needs to be tested now. So it's very important that we read all versions of the guideline and follow the most updated one. Or the patient has an increased risk allele or a pathogenic pathogenic alteration with reduced penetrance in an autosomal dominant gene, or a confirmed biallelic variant in an autosomal recessive gene. So we all know that there are mainly two types of inheritance, autosomal dominant and autosomal recessive. So when I told about matching the genome patri, so we talked about autosomal recessive. So any autosomal recessive and heterozygous is not going to really manifest. So biallelic variants means it has to have that second variant also. And autosomal dominant, even with reduced penetrance, for example, BRCA or any of the HBOC related genes can also cause a positive phenotype. Negative did not meet the criteria for positive, carrier, or uncertain group criteria. So the uncertain is at least one VUS, which is the elephant in the house for all of us. That because as lab personnel, we also don't know what to do with it. The clinicians also don't know what to do with it. And at the end, we end up telling the patient also that we don't know what to do with it. So you have a VUS. So the protocol which we follow is that once you detect a VUS, it is advised and you tell the patient that you come back to us every 3 months and we revisit the status of the VUS through all databases, because I don't think most of the labs in India have the capacity to do a functional test to actually prove whether that mutation is disease causing or not. So the thing which we follow is that we revisit the VUS every 3 months, or maybe you can reduce the frequency and make it biannually, and just to keep a track whether the status is changing to benign or pathogenic or not, because it gives a lot of relief if it changes to benign. And it did not meet the positive or carrier group criteria. Carrier is when there is only one variant which is classified as pathogenic or low likely pathogenic, or an increased risk allele, or a pathogenic alteration in a gene with autosomal recessive inheritance. So when there's one alteration in autosomal recessive inheritance, then probably the patient is a healthy carrier. And possibly, what to do with a carrier. So it becomes important, especially in the department in which I work now, is hematology and bone marrow transplant. So if I know that the patient is affected with a germline alteration, which is probably causing the disease, and the donor is a sibling donor or a parent, then I would first confirm that the donor does not have the same alteration, because if we are transplanting with the same stem cells, we are putting the disease back in the recipient. So it's very, very important that we know the healthy carrier status also. So what is the hereditary mutation landscape in a lung cancer patient? So this is the study which was published in JCO Precision Oncology by Saucher et al. And if you see that, close to around 15% patients do have some germline alteration in lung cancer. And if you see, the common ones are related to BRCA genes and also ATM gene and also CHEK2 gene. But CHEK2, interestingly, is protective, which I will talk about more in my subsequent slides. And very interestingly, EGFR, the T790M mutation, which is the T790M mutation, which usually occurs after second generation TKI treatment in lung cancer as a resistance mutation can also be germline. And this is very interesting because supposing if you have a patient of stage 4 lung cancer with an upfront T790M, a treatment naive patient who has an upfront T790M with another driver EGFR, it is very important that you go back and just do the same T790M tube in a single gene assay on a peripheral blood germline sample just to confirm whether it is germline or not. So it's very interesting because we usually followed this as a practice in our setup. So single gene heritability, and this was a very landmark study. I really like the study because it was close to 7,788 patients, and a positive result was identified in 15% with a cohort of 1,161, which is a very, very good number. And 61% patients they found that were eligible for a clinical trial based on the identified variant in a DDR gene. So this is phenomenal that even if you do a germline testing and you can find patients eligible for a clinical trial, you're doing so much good. And carrier result was seen in 2.9% and almost 32%, which is a huge burden, was had an uncertain result. So this VUS, I think we need more testing labs and we need more labs who can actually help us with functional studies, which is completely beyond my brain and my intelligence. And very interestingly, why I put this graph was because if you see the South Asian population, which is the fourth panel, is also very interesting because you have positive status as well as a carrier status, huge burden of uncertain status. And if you see, there are more VOSs in South Asian population, and the positivity is almost similar. However, we are little less than the other African American and Europeans, although Europeans are very highly this thing. But then that I think is because of the BRCA2 gene, which again I'll be talking about in my subsequent slides. So this is another study by Maurice et al. And they also, showed almost the similar mutations which were detected in Saucher et al. But also PARK2 is something which I would highlight over here. And otherwise, the same DDR genes and also the EGFR T790M. But interestingly, here they got a result of 0.04%, whereas the other study, which was a landmark study, had 1% for EGFR T790M. So cancer type alterations and susceptibility, if you see this table kind of summarizes that what mutations may be associated with which histology with a higher odds ratio. So if you see EGFR T790M clearly as expected would be associated with adenocarcinoma, and the therapeutic implication will be the third generation TKI, which is osimertinib. I don't know how much. I think it is yet to be studied that whether there will be any alteration because it's a germline alteration, and how much of the mutation burden is going to really come down. We are yet to see that. And RB1, we all know that almost 100% cases have co-mutations in TP53 and RB1 when there is a neuroendocrine tumor in the lung, like small cell carcinoma or large cell neuroendocrine. But RB1 germline is also likely to cause small cell lung cancer, or even it can also help in a faster small cell transformation of an EGFR TKI treated lung cancer. BRCA2, the 3326 termination mutation predisposes to a squamous histology, but I have circled this for a reason. Interestingly, I'll show you what it is because I've had very good experience with this mutation because we've detected it in so many patients. And initially, when I guess our knowledge was less, we ended up calling this mutation pathogenic, and later on, we realized that this mutation is actually not pathogenic. ATM mutation, again, a part of the BRCA pathway associated with adenocarcinoma. CHEK2, although it's written squamous histology, but look at the odds ratio, it is only 0.3. It is likely to be protective for this squamous cell carcinoma. TP53R72 Pro, again, is a polymorphism which kind of, because it's in a linkage disequilibrium, it kind of predisposes, but in Indian population, close to 70 to 80% individuals for any cancer type you sequence, you're going to find this mutation. PARK2, again, for adenocarcinoma, and it is probably more sensitive to chemotherapy. So this is what I was talking about, that BRCA2 in 2024 in the FDA recognized database also has been confirmed benign, but it's still, people say it has a BRCA2 related cancer predisposition because it is again in a linkage disequilibrium. So this is something which we have to understand, that it is at the end of the coding region of BRCA2. So likely um, causing a loss of functional protein is very less, and that is why probably it has been conferred a benign status, and it is very common in the Indian population to be actually called as pathogenic, because we, at least in our experience of almost doing around 2000 3000 BRCA sequencing, we found almost close to 18 to 19% patients having this. And obviously, you can't really have a mutation which is present so commonly. Check 2 and lung cancer, there is a lot of hype recently. There are a lot of papers which have enumerated what happens in Check 2 driven lung cancer. So, one mutation, I157, decreases the risk of lung squamous cell carcinoma. Very interesting, with a hazard ratio of 0.2. Why? Because the MAF can be as high as 5% in Eastern European population. And if you look at the Check 2 mutation distribution, it is distributed all across the gene, even in the non-coding regions as well. And if you also look at this, so what is interesting is the lower pie, because Check 2 driven lung cancer, almost 18 to 20% patients are going to have some actionable oncogene, and also KRAS also. And although KRAS only G12C is actionable, but then KRAS, if present alone, can help the patient with immunotherapy. So I think it is very important that we don't really hold back the Check 2 in, the report, because sometimes we tend to not report variants which are not related to the disease phenotype. So as a practice in any germline testing, what you should actually do is you should segregate the report into the variants related to the phenotype and incidental findings, just like the recommendations tell you. And it is very important you convey that if there is any mutation in a particular, especially DDR pathway gene. So a word on EGFR T790M. My question is, what would you do? So there was that INHERIT trial, which is the largest prospective study of individuals harboring EGFR pathogenic germline variants. And after 5 years of enrollment, they saw that 55% participants with germline T790M were diagnosed with lung cancer before the age of 60 years. So this is very interesting that, once you actually do a somatic upfront EGFR testing, and if you find a T790, it is very important you convey to your clinician that you want to do a germline confirmation before you move ahead. And very interesting, it is associated with bilateral ground glass pulmonary nodules. This is for my clinician friends, that certain subtle hints that they might be harboring a T790M germline mutation. Other less common genes and loci, PARK2, I told you, has been associated with a large effective size in an adenocarcinoma patients, more prevalent among patients with early onset lung cancer, that is less than 40 years of age. The other rare syndromes are Bloom syndrome, Werner syndrome, all the Fanconi related genes, RB1, mainly SCLC, and even BRIP1, which is a part of the BRCA pathway, again SCLC. And some genome-wide association studies have found loci which are enriched in lung cancer, and they are enumerated here on chromosome 15, 5, and 6. Why? Because many of these harbor the microsatellite instability genes, as well as the MRN complex genes, as well as some DDR pathway genes, which are very, very critical. And I thought, enlisting each and every one of those here is actually going to cause a lot of it's cause a lot of clutter on my slide. So that's why I didn't, because there are close to almost 15 to 20 genes when you take these loci together. So I would actually direct everybody to read a new paper, which a review article, which is published in JCO just in 2024, and it's right now only online. I would really redirect everybody to read that article about germline testing in lung cancer. It's a very interesting read because it talks about all the loci, it talks about single genes, it talks about multiple genes, it talks about TP53 separately, and it's a very interesting read. So, what is the testing strategy and tools? This strategy is developed. So I try to do it on myself, and then I realized that okay, it is kind of aligned to what people have reported. So if you have a newly diagnosed lung cancer and you're suspecting a hereditary cancer syndrome based on the patient's family history, or even um, personal history of malignancies, then if you're suspecting an HBOC related or a BRCA related disorder or a leaf from any syndrome which is TP53 related, or an EGFR T790M, a focused germline testing that is using a tight panel, maybe, encompassing only inherited cancer predisposition genes of maybe ACMG list would be enough rather than going in for a whole exome or a whole genome approach, because you know what you're looking for. Probably, you can just do a tight panel testing because that would cause less financial burden on the patient as well. But if you're not suspecting something hereditary cancer syndrome based on the family history, then I would say an early onset and family history of only lung cancer and no other solid tumor, and you're not able to get a genotype phenotype correlation. And if it's a young non smoker, or you have some very rare histology, or the patient has multiple primaries, then because we don't know what we are looking for, we are searching for the needle in the haystack, then it is better to do a whole genome or a whole exome approach. So my choice over here is a whole exome approach, and or in fact probably coupled with an MLPA, because just to look for large deletions. And my MLPA would include probably the MSI genes and BRCA only, because again, MLPA is again costly. So I would go for a whole exome approach coupled with an MLPA. What are the tools and panels? Again, as I said, single gene T790M, you can confirm on a peripheral blood sample using your own EGFR test, whatever you're using for the FDA approved, one of the FDA approved platforms. And rest all genes, you have to do a panel based NGS. Either you do a smaller panel like HBOC, or a focused inherited panel coupled with an MLPA again, or you use a whole genome or whole exome approach. Again, my choice is whole exome approach coupled with MLPA. So what is the evidence for screening? So this was this very interesting trial which was done, which was a talent study in Taiwan, which was a national lung cancer screening program where they coupled low-dose CT scan with family history of lung cancer, and they followed the patient up to 10 years and even beyond, and they found that 4.5% overall detection rate of 4.5% at 10 years, but the rate rose to 7.4% for individuals who had several relatives with lung cancer. So I think the role in screening is also coming. And so probably we as lab personnel and we as molecular experts, or people like Dr. Skaria and the people who design panels and validate panels, I think the task is yours, that you need to somehow bring down the cost, and so that we can use it as a screening tool for everybody who's diagnosed with a lung cancer, not only with a family history. So what my evidence was, what we actually did was that we took all young non-smoker NSCLC patients. So we didn't take any small cell lung cancer patients, very, very tight cohort, 40 years and younger, and only NSCLC, only adenocarcinoma, no squamous, and never smokers. So we got 48 patients, and we did a whole exome approach using the whole exome panel from Twist, and we found that there was a genetic germline alteration in close to 58% patients, and the pathogenic, likely pathogenic variants were detected in 16%. But if you interestingly see, the mutational profile detected in our cohort is completely different from what has been reported in studies, with BRCA1, BRCA2 being common, TP53 being common, but RAS F1A, NF1, and VSIG10L. So this really got me also thinking, because I had never heard the name of VSIG10L until I saw it in two patients in our cohort. And interestingly, that patient's family members also tested positive for that gene. Similarly, RAS-F1A also, we had one first degree relative testing positive as a healthy carrier. And we had one EGFR T790M mutation as well. So clearly, Indian landscape differs, and we need to expand this study more. We need to test more patients, and we are still doing it. And this data currently is not published, but has been submitted as an abstract for a meeting, and probably the abstract will be published in one of the journals. But we will write it up, but after probably we expand the cohort a little more. But what I want to say is that, probably it is very important that we um, have to devise some approach in India, because I think the Indian landscape differs from the West, even in terms of germline, just like somatic lung cancer differs from the West. So, what's the future? Screen all lung cancers at diagnosis, probably with a whole exome, whole genome approach, but somehow bring down the cost for that, because everybody cannot afford. And again, there are a lot of bioinformaticians, even including Adira, who just gave me a very big introduction. But what you do, I can't do. So AI-based modeling to predict possibilities through, some low-pass WGS. So we can even include the loci which are involved on chromosome 15, 5, and 6. And, we need to actually unravel the Indian lung cancer genome, not only somatic, but also the hereditary mutation panel, because hereditary mutation landscape, because we don't know what we're looking for, and why so many people who are non-smokers are also getting lung cancer, and as early as 19 years of age also I have seen, which is very, very, very sad. So thank you so much, and ask the questions to the experts in this panel and not me. Thank you.
Thank you, Doctor. Very nice, insightful presentation, and very interesting data to look at Indian mutational profile, which seems not in concordance with what is already reported. Yeah, so the floor is now open for questions. You can put your questions in chat. Yeah, so the first question is, would you think patients with lung cancer should routinely get germline testing if they have family history?
Yes. Yes, I would really advise. So,
And
if you
yeah,
have a genetic counselor in-house, they can draw up a family pedigree of probably 3 generations and give you a kind of a genotype-phenotype correlation, and give you some hints that what genotype are you actually looking for when you have a particular phenotype which is there in the family, or a combination of different types of histologies or cancers. So I think it's very important we do a germline for everybody. I think you're
I was
mute.
mute. Yeah.
Yeah.
Do the families also need to follow up with genetic counseling?
Yes. So, as a rule, whenever you do a germline testing, you do a pre-test counseling first, because you need to understand what to test for, and the counselor needs to draw up your family pedigree. And once the results are in, you do a post-test counseling, because you need to understand what is there on the report, because the patients somehow they end up asking Dr. Google, and they end up getting anxiety, because that is the other edge of the sword of germline testing, that it creates a lot of anxiety in the patient and their kindred. So it is very important that the counselor explains properly the meaning of whatever is there in the report, because any whole genome or whole exome report is never going to be clean. It also has a lot of mutations which are there, as because we are all exposed to so many insults. So some benign diseases mutations will also be there, which we can't hold back. We have to put it on the report, but the patient starts thinking that we have cancer. So it's important that you follow up with the genetic counselor. They are going to draw up a prevention surveillance program and a preventive oncology surveillance program, which they need to follow.
Yeah, interesting. And should non-smokers with lung cancer also get germline testing?
So it depends, not all. So we tested all non-smoker young patients, that is early onset. Okay, so what I put down in my strategy was that supposing if there's no very strong suspicion of lung cancer, of having a germline variant in a never smoker patient, you can actually maybe skip it, and then maybe during the course of the disease, counsel the patient if you're not getting any answers. And maybe when you do a comprehensive genomic profiling somatically, where we are testing 550 genes or 680 genes, which end up covering most of the inherited cancer predisposition genes, you will get subtle clues from somatic testing also that a certain variant can be germline, and you can put it on your report and then recommend. So that's also one approach which we use just to save cost for the patient.
And next is a very interesting question. In terms of BRCA positives, are there clinical trials on potential use of PARP inhibitors in
Yes.
lung cancer?
There are a lot of studies which have been done already, and there are certain trials which are, the inclusion criteria includes lung cancer. However, the response till now is not promising.
Okay. And like you showed the results of germline testing, the next question is between germline and somatic genetics testing, which would give the better positivity results?
No, so both have different uses. Germline is something where we are looking only for inherited mutation, and somatic is we are looking for targetable alterations. So when we test a lung cancer for somatic alterations, the 12 genes which have, some actionable biomarker, those 12 actionable biomarkers which have some molecule available, we mainly look at that, or some co-occurring mutations which may hamper the targeted therapy efficacy. That is the somatic thing. But yes, the recent approach is that you do a very big panel of 550 genes or 680 genes, and from that you get subtle clues of germline. So that is one way of doing it, that you do a somatic testing, you get subtle clues of a certain variant being germline, and then you go and do an orthogonal testing for that same mutation, a site-specific testing on a germline sample. So maybe you can do that, but then doing only a somatic testing, and if that is negative for a germline variant, does not rule out that you do not have a germline variant.
Right, but I have a question. In the 83% where the pathogenic germline variant was not detected, did you not thought of pursuing a somatic testing for those samples?
Somatic testing is done as a routine for all lung cancer patients.
And they had a negative tumor NGS report, those
They
83.
had some actionable biomarker, but then that was somatic.
Okay.
There was no germline variant. So I would say that 83% I think is over exaggerated. Why? Because we didn't really do MLPA in this cohort, because we
Mm-hmm.
didn't have that much money. This was a self-funded kind of a study. So
Mm.
we didn't really do a MLPA, and we don't know whether we missed out on those things. And then because molecular is not matched, so probably some methylations and some microRNAs and things we definitely missed out.
And when do you think WGS would be the mainstay? Any specific situation where you would recommend it?
So I think WES is a better approach, because um, it is less work for all of us also. And but yes, WGS can be used, especially there is, I just know of one. If somebody else knows more, then they are welcome to add to it. But WGS, I know about GATA 2, which has a lot of intronic pathogenic germline variants. Okay, and because I come from the hematology background and GATA2 is very important, it also causes some variations in lung cancer also. So I am very that is the only place where I would probably think of a WGS approach, because and that also you will end up suspecting in a specific patient who's having a lot of recurrent infections in a dendritic cell deficiency kind of a situation and clinical phenotype. So that is one specific indication I know of.
And based upon the work that you have done and the diversity of the lung cancer patients you have seen, would you suggest any hypothesis that is required, needs to be verified through a clinical trial, especially for an Indian setting?
So see, my idea is that I'm very interested in what happens in never smokers who get lung cancer. So, people who have never smoked and are getting lung cancer, it can be because of two, three reasons. One is because we live in a environment, at least I live in Delhi, and that's the pollution capital, I think, of the universe. Okay, and so how is my genome getting affected by PM 2.5 versus somebody else who's living in a clean environment? I don't know which environment is clean, but comparatively clean, like Kerala or somewhere. And you know how different it is, and what is the germline alteration in all of us, and whether is any germline alteration going to affect the efficacy of targeted therapy what we are using in lung cancer? How does it affect the efficacy of targeted therapy? Because we are looking at PFS of 37 months, 38 months with lorlatinib, with alectinib. We are looking at PFOS of close to almost 48 months with these drugs. But are germline variants actually causing any issues? So all these trials never look, I don't know whether they looked at germline variants and they're yet to bring out that analysis. They must have, but they have still kept it very exploratory, I think, and they've not really analyze the germline variants with the survival, because obviously drug driven. So I think
Hmm.
we have to see that.
Very interesting thing to pursue. How do you think we could spread awareness on the requirement of germline testing? What strategies should we take?
So I think right now germline testing is a very big taboo in India. Okay, because many women don't undergo germline testing, thinking that their in-laws will get to know, and so there is a lot of social taboo associated with number one. Number two, some people think that agar pata chal gaya, to we will die of anxiety, and some people end up thinking that we will definitely get some cancer, so they
Hmm.
avoid, ignorance is bliss. So that is what is the feedback which I get now every day, because right now I'm really running a genomic clinic at Fortis, and I end up talking to so many patients, and this is the feedback which I get. Not many people are very open to doing germline testing because they are scared of the findings. So we need to make them aware through probably all our social media platforms, through webinars for lay people, which is very, very non-technical, and make them understand that, it is very important that we know, so that not only you, but your future generations can also be saved.
It's the need of the hour. You also showed the lung cancer in had TP53 mutations, right? So what's your take on this Lee Frommany syndrome and EGFR mutated lung cancer?
So, interestingly, I could not put that on my slide because, it was late. Um, just 2 or 3 days back, we got a case where 11 people in the family were affected, and the patient was a hematolymphoid malignancy. But out of the 11 people who were affected, there were like around 6, 7 patients who were affected by CML, but there were 3 lung cancer patients also. So, and it was documented as a TP53 mutated patient, and it was Lee Frommany syndrome. The patient was only 16 years of age with hematolymphoid malignancy, and he also had an EGFR del 19. So now I'll tell you my experience with somatic testing for EGFR mutated lung cancer, that in Indian scenario, TP53 is not statistically significantly related to the efficacy of osimertinib. Okay, there is no difference with TP53 mutation plus or minus, at least in our experience of 800 EGFR mutated patients. So we didn't really have that problem with TP53, because I think in Indian scenario, the prevalence of TP53 is very high in the somatic range also. So if it is not affecting the efficacy of EGFR TKI in the somatic thing, I'm not very sure if germline is going to really affect, but we need to see that data. That's why I said that my idea of a trial would be to see the efficacy of all actionable biomarkers.
Interesting. And I would like to invite Dr. Vittala to ask in person, if possible.
Hello, Dr. Dara. I missed your question. I'm sorry for that. Can you please?
Yeah, I was inviting you to ask your question in person to Dr. Srinidhi.
Hi, Dr. Srinidhi. It was very pleasure when listening to your talk, and you've really done justice by bringing in a lot of things. I was just having one question. What do you think about the secondary lung coming out of the hormone-sensitive prostate cancers? Because when you see the genomic alterations which are there currently, predominantly it also plays a role in prostate. So there was some paper, I believe, in JCO recently, and you would you like to take a call on this?
So I think those are very early days, and hormone sensitive prostate cancer, or in fact even breast cancer, I have seen a lot of secondary lung malignancies coming out. So maybe even if we test and we, probably again, it is more important that test. Many people don't undergo the test. So I would right now say it is too early to comment on that till we actually have more data and we can test more.
Okay. The way the uro-oncologists are also started using genomic testings for prostate cancer. At the end of the day, the secondaries also makes hormone resistance is a very slow growing process, and when the secondary meds come in, it really comes in at a very aggressive stage. So, does this genomic profiling for such patients make some sense to them and help them plan the treatment?
Yes, it does. It does. And I think now more and more, even the surgeons are becoming aware that it is important to test. First, initially they used to do only somatic. Now they do somatic, PET, somatic, and germline also. So it's very important that, when we are advising them what panel, we don't end up doing, very tight panels that time, because that time we have an opportunity to test the patient. And, as molecular scientists and experts in the field, I think it is our responsibility that we bring out that data and we create that data first. So if we end up following a very tight panel approach for germline, we'll never end up deciphering what we are looking for.
Thank you again for your wonderful talk. Thank you.
Thank you. Thank you so much. Thank you for inviting.
Dr.
So on
Dara.
this note, yeah, thank you, Dr. Mitra. So on this note, let's thank Dr. Srinidhi for her precious time to enlighten us on the nuances around germline testing in lung cancer. With that, we conclude today's session. Thank you, and thank you to all the attendees for your participation. And we will be soon notifying you about our next webinar, and we hope to see you soon. Thank you once again.